Okay, it looks like it's time for us to go ahead and get started here. Hello, everyone, and welcome to this month's Northwest ATTC webinar. I'm Jennifer Verbeck, and I'm your host for today. We're excited to have Dr. Susan Stoner presenting for us today on the Parent-Child Assistance Program, supporting substance use disorder recovery for pregnant and parenting women. A couple of quick housekeeping things. First, if you have any questions for our presenter, please type them into the chat box at any time, and we will try to answer as many as we can at the end of the presentation. You'll also be getting an email at the end of today's webinar that has a link to a survey in it. Please take that survey. It helps us make sure we're bringing you the content you are most interested in. That email will also have a link to download the slides from today and a link to our website where you'll be able to find a recording of the webinar. And that should be available later this afternoon. Additionally, we'll be sending everyone who attends the live webinar a certificate of attendance, and that takes us about a week to get those out. You don't need to do anything to get the certificate unless you're watching this in a group. In that case, please have someone in the group email us within a business day with the names and email addresses for everyone who wants a certificate. And you'll see our email address up there on the slide. It's northwest@attcnetwork.org. Okay, now on to the webinar. I'm pleased to introduce our speaker today, my coworker, Dr. Susan Stoner, who is a licensed clinical psychologist and a research scientist at the University of Washington's Addictions, Drug, and Alcohol Institute, and she is also the director of the Parent-Child Assistance Program. And with that, I'll go ahead and turn it over to you, Susan. Thank you.
Okay, great. Thank you, Jennifer. So welcome everyone who's been able to tune in today, and a special welcome to all the Pcapp staff who I know are in attendance. Again, the title of my talk is the Parent-Child Assistance Program, or Pcapp, Supporting Substance Use Disorder Recovery for Pregnant and Parenting Women. I'd like to start with a tribal land acknowledgement. In applying a lens of cultural humility to issues of diversity, equity, and inclusion, the Northwest ATTC, of which I am a member, offers this land acknowledgement for today's event. Our work intends to reach the addiction workforce in HHS Region 10, which includes Alaska, Idaho, Oregon, and Washington. Now, this region rests on the ancestral homelands of the indigenous peoples who've lived on these lands since time immemorial. And so I'd like to invite you all to join us in support of efforts to affirm tribal sovereignty and in displaying respect and gratitude for our indigenous neighbors. So I'm going to start out by talking about women's substance use. Substance use by women aged 15 to 44 has increased yearly from 2016 to 2019. This is data from the National Survey on Drug Use and Health. And now the way this way the scale works, it doesn't look super dramatic, but you will note that there's been an upward trend over the last 4 to 5 years. This is noteworthy because compared to men, women become addicted from using smaller amounts of drugs for less time, have more drug cravings and are maybe more likely to relapse, are more sensitive to drug effects due to hormones and other physiological differences between women and men, like metabolic enzymes. And consequently, they are potentially prone to higher rates of overdoses and emergency room visits in response to the effects of substances. I also want to note that problematic substance use puts women at risk of victimization. So being victimized, but then I also want to note the reverse is also true, that being victimized so puts women at risk of problematic substance use. Problematic substance use also puts women at risk of sexual risk-taking and unintended pregnancy. So focusing in on substance use during pregnancy, while many women stop using substances when they become pregnant, those with a substance use disorder or SUD might find it difficult to do so. And this might be especially true among women who have been victimized. And that includes those experiencing intimate partner violence and those with a history of adverse childhood experiences, or ACEs. Rates of substance use during pregnancy are lower than not during pregnancy, and they've fluctuated over the past 4 to 5 years, but they remain concerningly high. Um, you can see women have really kind of gotten the message that binge drinking during pregnancy is a risky thing to do. And so that's actually one of the lowest substances that women use. But there's still relatively high rates of marijuana and illicit drug use. Now, this is concerning because prenatal substance exposure puts children at risk due to the possible effects of prenatal exposure on fetal health and development, the likelihood of being born into and growing up in an adverse home environment, and then consequently, the possibility of being removed from the home. And if that happens, that of course puts the mom at even greater risk of problematic substance use. So this is something we really want to try to intervene with. So you note that this kind of occurs in vicious intergenerational cycles where we have ACEs related to both substance use disorders and intimate partner violence. And these are related to each other. And then these are also, as a constellation, are related to another constellation of poor mental health, adverse home environment, and unintended pregnancy. And these are all interrelated. So you can kind of see how these are kind of vicious cycles, and they're wrapped up in cycles of stress and coping, albeit perhaps maladaptive coping. But it's important to keep in mind that clients with substance use disorders and histories of ACEs are really just doing the best that they can in their environments. Now imagine if you have the added stress of a substance exposed child who may have special needs, and then also an additional stress if there's loss of custody. This can sort of feed into that stress and maladaptive coping cycle and potentially result in ACEs for the child. So there's this intergenerational cycle that is often going on with intergenerational transmission of substance-related problems. Also keeping in mind that this is all sort of happening within a social ecological context. So some of you might be familiar with Bronfenbrenner's ecological framework for human development, where there's kind of this microcosm of what's happening with the individual and family, but that's embedded in a context of family, peers, work, if that's relevant, school or church, if those are relevant, but other systems. And then this is integrated in larger systems of SUD treatment, medical and mental health services, social services, and community services. And when you're embedded in these layers, it can be hard to access community and other services that could potentially be beneficial. So that's really where Pcapp comes in. So the Parent-Child Assistance Program is an award-winning 3-year case management model. Services are provided at 15 sites covering 19 of the 39 Washington counties, and that actually covers a majority of the state population. Pcapp serves over 1,400 at-risk mothers in Washington state. And we aim to help pregnant and parenting mothers with substance use disorders achieve and maintain recovery, build healthy family lives, and prevent any future children from being exposed to alcohol and drugs, particularly during pregnancy, but even beyond that. So just to give you a little bit of history about Pcapp. Pcapp arose from a study of prenatal cocaine exposure, which was being done by Dr. Ann Streisketh at the University of Washington. The Pcapp founder, Dr. Therese Grant, my predecessor, who was the previous director of Pcapp, worked on the study of prenatal cocaine exposure. And through that work, she got to know many of the mothers who were enrolled in the study. She actually went to their homes to sort of bring them to the university for assessments. And in getting to know them, she was really struck by their histories, their difficult life circumstances, and their resilience in the face of these challenges. She noted that they wanted to be good mothers, but in many cases, they just couldn't due to their circumstances or didn't quite know how. So they decided to put together an intervention to really help women, pregnant and parenting women with substance use disorders. And SAMHSA funded the initial study and intervention development. So this just kind of gives you a little bit of a timeline from 1991 to 1995. UW conducted SAMHSA-funded research that developed the original program. Then there was some philanthropist funding, and Pcapp sort of was refined over the years. From 1997 to 2021, the state of Washington picked up funding for Pcapp and sort of expanded to the point where now we have 15 sites covering, that should be 19 counties. And Pcapp has also been replicated outside the state of Washington in Minnesota, North Carolina, Alaska, Texas, Nevada, Louisiana, Pennsylvania, Michigan, and California. And internationally, it's also been replicated in Canada and Western Australia. So just to show you where we are in the state of Washington, all of the purple counties are covered by Pcapp, and those are the most populous counties for the most part. So I want to point out, with roots in studies of substance-exposed babies, Pcapp has really strongly emphasized prevention, but intervention with mothers with substance use disorders is not only about prevention. Recovery in mothers with substance use disorders is another major emphasis. Want to really make a point that the well-being of the mother is just as important as the well-being of the children. And indeed, most of our outcome measures focus on improvements in mothers' lives. So to address the theoretical framework of the model, Pcapp weaves together three key theories: relational theory, the trans-theoretical model, and harm reduction theory. So relational theory emphasizes that a person's sense of connectedness to others is central to their growth, development, and definition of self. Positive relationships in intervention, treatment, and recovery settings are absolutely critical from this point of view. Relationship quality may be more important to client retention and improvement than the nature of the actual services provided. And so Pcapp really fosters relationships between the client and the case manager, the program, and other sources of support. I just have a nice quote on that from a Pcapp client, an actual Pcapp client. For me to overcome my addictions to traumatic childhood, I needed every piece of the puzzle from all the services I was involved with. However, it was my relationship with my Pcapp advocate that helped me translate everything that people were telling me to do. That relationship is really critical. So Pcapp also incorporates the trans-theoretical model, which emphasizes that persons are at different stages of readiness for change. Behavior change in this model is viewed as a process that involves moving through the stages of change, which many of you may be familiar with: pre-contemplation, contemplation, preparation, action, and maintenance. It sounds like a linear progression, but change is not always linear. People can move back and forth, drop out, pop back in, but different stages call for different approaches to support development of self-efficacy. And throughout the stages, Pcapp uses motivational interviewing to develop discrepancy and enhance motivation for change. And then harm reduction is a theory, emphasizes that addiction and associated risks are on a continuum. It really seeks to meet clients where they are without demanding abstinence as a condition of treatment. Any steps towards decreased risk are viewed as steps in the right direction. And accordingly, Pcapp views abstinence as kind of the ultimate harm reduction, but it doesn't reject clients who relapse or choose to continue using drugs or alcohol. I also want to really emphasize that Pcapp supports recovery in mothers with substance use disorders. It's a major emphasis of SAMHSA, and according to SAMHSA, recovery is a process of change through which people improve their health and wellness, live self-directed lives, and strive to reach their full potential along 4 major dimensions: health, home, purpose, and community. And Pcapp targets all of these dimensions. So Pcapp works with mothers for 3 years, and these are pregnant and parenting mothers who have substance use disorders that impede their ability to care for their children and live healthy, functional lives. Our data show that most mothers in Pcapp were once themselves neglected and abused children in our communities. 89% had parents who abused alcohol or drugs. 65% were physically or sexually abused as a child. 24% of them were involved in the foster care system themselves as a child. And 35% didn't finish high school or obtain a GED. So these are really significant challenges that people in our program have grown up with. And long-standing problems really require a long-lasting intervention. And that's why Pcapp is a 3-year program. You can't change these types of vicious intergenerational cycles with just a short-term intervention. So the Pcapp approach incorporates case managers who do outreach and engagement. They provide mothers with structured goal setting, problem solving, practical assistance, and consistent coaching. They work to ensure that clients and families receive needed services and seek to help community service providers work more effectively with Pcapp clients. We call this our 2-pronged approach. So who are the Pcapp clients? To be eligible for Pcapp, clients have to be pregnant or up to 24 months postpartum. We prioritize 12 months postpartum, but we do accept people up to 24 months postpartum if space allows. They have to have had some heavy alcohol or drug use during pregnancy. We're not talking a drink or substance use here and there. It would be something that would potentially really impact the well-being of the child. And they can't be effectively engaged with community services or otherwise. That's a major thing that Pcapp does to help people, is get them connected to community services. So there has to be a need there. Alternatively, clients can be enrolled in Pcapp if they already have a child with fetal alcohol spectrum disorder and are currently using alcohol problematically and are in their childbearing years or capable of bearing a child. So this is, again, sort of from that history of prevention, wanting to prevent future substance-exposed births. So who are the Pcapp case managers? Well, they're highly trained individuals who receive twice monthly supervision, average caseloads of 16 mothers. We really value lived experience in the Pcapp model. case managers are not necessarily peers in the traditional sense, but many have their own history or experience with motherhood, substance use disorders, or other challenges that they can share to help be a role model and inspire hope. So they meet with mothers twice a month and in the mother's own homes whenever possible. We really emphasize the value of seeing women in their own environments to really kind of understand what is going on and what the needs are. This again comes from the ethos of kind of meeting clients where they're at, literally in their homes, and if not in their homes, in their communities. So Pcapp is not a desk job for a case manager. Case managers really go out and work with the clients. They offer transportation for clients' important appointments. And this is, they're not just like an Uber or a taxi driver. This is a really important time for case managers to be able to engage with the clients, hear what's going on for them, and get a window into their lives so that they can support them. So the Pcapp model of case management really puts the client at the center and recognizes all of the possible, all of the relationships and support surrounding that client, from their child to the child's father, and maybe they have a different current partner, their relationships with their siblings, friends, caretakers, extended family, roommates, neighbors, all of those around them. And Pcapp seeks to sort of take this network of relationships into consideration while helping the client get connected to community providers for treatment, family planning, education development, mental health treatment, and medical care, also navigating CPS when CPS is involved, or probation when that's involved. So it's really kind of a holistic approach, really seeking to get the client connected to the available services in the community. And it's important to note that all of the counties across the state don't have the same resources, right? So what Pcapp in one county might look quite different from Pcapp in another county just by nature of what community resources are available. But the approach is similar. So just to kind of describe, really the hallmarks of Pcapp are that it's client-centered. Clients, like I said, are put at the center of that case management, but they're also, case managers work with clients to help clients identify their own needs and goals, to prioritize them and to take steps toward achieving them. As I mentioned, Pcapp has this two-pronged approach where case managers work with clients, but also with service providers. Pcapp also really takes a pragmatic lens, using a problem-solving approach to addressing service barriers. And again, Pcapp really seeks to meet clients where they are, in addition to the harm reduction ethos. Like I said, home visits are really strongly encouraged because it really helps get a window into the client's life. So I have another little quote here from an actual Pcapp client. Before Pcapp, I never thought about goals. They showed me the right direction. They showed me that I'm responsible. No matter who I am or what I do, I'm somebody. It's never too late. So I hope this works. We have a little promotional video that was produced with the support of Molina Healthcare, and I thought it kind of gives a nice little summary of Pcapp. Play it.
Addiction affects people from all walks of life. It can impact any woman, man, and family in any neighborhood. When alcohol or drug use gets out of hand, it affects our friends, our family, and those we care about deeply. Sometimes addiction affects the strongest among us, and sometimes the most vulnerable. Since 1991, the Washington State Parent-Child Assistance Program, or Pcap, has helped pregnant and parenting mothers with substance use problems. Women in Pcap are matched with a case manager who helps them access local resources. Women who enter the program often report a history of trauma. Most grew up with a parent who used drugs or alcohol. Many experienced abuse. Some were placed in foster care. Often they did not finish high school. Pcap case managers understand trauma and seek to become a stable, positive presence in women's lives. Over the course of 3 years, case managers help mothers to achieve and maintain recovery. They help women set goals and take steps to reach them. With their case manager's support, women are able to overcome challenges like finding treatment, obtaining health care, securing housing, escaping domestic violence, and navigating child custody issues. Women who complete Pcap demonstrate positive outcomes. They attend to their health and the health of their children. They expand their support systems and lay the foundation for stability for their families. Over time, they build self-sufficiency and well-being. Researchers at the University of Washington have found that women who completed Pcap had high rates of completing needed treatment for alcohol or drug use. Rates of substance use decreased dramatically during the program, and very few participants had a subsequent child who was prenatally exposed to drugs or alcohol. Pcap works because it provides women with 3 years of practical assistance and the emotional support that is often essential to making fundamental life changes. We care because they're our sisters, our daughters, our friends, and our neighbors. Currently, Pcap is offered in 19 Washington counties and several locations outside of Washington state. Thanks to programs like Pcap and partnerships with the University of Washington and Molina Healthcare, we are able to make a difference for women and children impacted by addiction. We all benefit when moms and their kids are substance-free. This message is brought to you in part by Molina Healthcare. Molina is proud to support Pcap.
Okay, how do I get out of this? Oops. I just stopped my share. Let me do that again. Oops. Okay, 1 second. No. Okay, so I'd like to now talk a bit about Pcapp outcomes. So among 1,209 Pcapp graduates from 2014 to 2020 at exit from the 3-year program, 90% had completed alcohol or drug treatment or were currently in progress. 75% were abstinent from alcohol or drugs for 6 months or more during the program. 68% were using family planning regularly. 54% had attended or completed classes such as GED, college, or work training. And 70% had custody of their child, the child that they were postpartum with or pregnant with when they started the program. Another 10% of those children were in the care of other family or a friend. So Pcapp has a good track record of supporting mothers to keep their children, keep custody of their children or keep them in the family. So during the 3-year intervention, almost 80% of participants did not have a subsequent birth, and that I like to think is in part due to the emphasis on family planning. But of those women who did have a subsequent birth, less than half of them were alcohol or drug exposed births. So only 10% of women had a subsequent child during the program that was drug or alcohol exposed. And from beginning to the end of the intervention, 91% of clients were using illicit drugs when they started the program. It's not 100% because I'm not counting alcohol or marijuana here just for the purpose of this slide. But at the end of the 3-year program, only 21% were reported illicit drug use in the prior 30 days. Only 6% were using reliable contraception at the time they got pregnant with the child that kind of brought them into Pcapp. But at the end of the 3-year program, 62% were using a reliable contraceptive method. At enrollment, only 29% were in permanent or stable housing. By exit, that number was 68%. 42% of mothers were receiving TANF as a primary source of income at enrollment, and now that was reduced to 22% at exit. Now, only 8% of clients were employed when they were enrolled in Pcapp, but by exit, 39% of clients were employed. So just to kind of give you an idea of outcomes over time, we see really consistent outcomes over time. So you can see these numbers are pretty similar over the last 3 years. The follow-up rate has gone down a little bit, and we think that might be in part due to COVID. It's just been harder to get clients kind of back in to do the exit interview, but the number is still quite high in spite of the pandemic. We have consistently high rates of substance use disorder treatment or participation, and pretty good rates of abstinence at exit for 6 or more months. Now, keep in mind that we don't throw people out if they relapse or if they don't have abstinence goals. So I think these numbers, kind of reflect that, but are still quite, I think, pretty impressive. And more than half of clients had abstinence in Pcapp of greater than a year. And I'd like to think that is in part due to the support that the case managers give to the clients. So now just talking a little bit more about family planning and mental health services outcomes. Again, very consistent numbers in terms of using family planning regularly at exit, and using a more reliable method in a majority of clients. And by that, I mean like the shot or oral contraceptive pills or tubal ligation or something like that, not a condom. And a majority of our clients were connected to needed mental health services at exit. And that's been pretty consistent throughout the years as well. So you might be wondering, like, how much does this cost and who pays for it? So Pcapp funding is currently administered through the Washington State Healthcare Authority Division of Behavioral Health and Recovery. Funding is provided through state legislative appropriations. Current annual direct services costs are across the state are $9.1 million, and almost half of that is covered by Medicaid, and the other 55% is covered by the state. Direct services costs are $64.64 per client per year. And then in addition, the University of Washington receives funding to conduct program quality control, training, and outcome evaluation. But we have demonstrated in multiple ways that investment in Pcapp is actually produces a return on investment because Pcapp produces cost savings. It prevents future children from being exposed to alcohol and drugs through either the mother's abstinence from substances or effective use of family planning. It decreases welfare costs as women stay in recovery and become able to work. It decreases foster care costs as more people become able to care for their children. So investment in Pcapp translates into fewer substance-exposed infants. 12% of Pcapp mothers had a subsequent alcohol or drug-exposed infant in 3 years. Actually, that's an old number. It's actually 10% in the most recent evaluation period. By comparison, 21% of similar mothers in a nearby state who received typical SUD treatment alone over a similar time period did so. And there's the citation for that, which is on the Pcapp website if you're interested in this article. Investment in Pcapp also translates into reduced costs to the public. The estimated lifetime cost for an infant born with fetal alcohol syndrome, for example, is $2 million, considering all of the healthcare that is needed and support. Pcapp shows over 20 million in lifetime cost savings due to effective intervention for Pcapp mothers who were former binge drinkers. And if you're interested in the citation, you can find that on the Pcapp website. I'll have the link at the end. Investment in Pcapp also translates into reduced costs to the public, as I noted. In fact, economists found that in Alberta, Canada, Pcapp prevented about 31 cases of FAS or FASD among 366 clients in a 3-year period. And so doing the math, the net benefit was $22 million. And this is likely an underestimate because they didn't take into consideration reduced unemployment. And this is a citation for that. You could also find it on the Pcapp website if you're interested in reading more about it. Investment in Pcapp also translates into less dependence on child welfare. Pcapp children who were in out-of-home care and reunified at Pcapp exit had a shorter average length of stay, 3.8 months, than the Washington State average, which is 20.4 months. And when you think about that, each successful reunification translates into a cost savings of over $21,000 per child. So there's significant money being saved here. Again, you can find the paper on the Pcapp website if you're interested. Investment in Pcapp also translates into less dependence on welfare, as I noted. From 2014 to 2020, temporary assistance for needy families, or TANF, was the main source of income for 42% of the women entering Pcapp, compared to only 22% at exit. And that's captured in our annual report. Oops. Okay, so in conclusion, just want to say maternal substance use disorders are really a nationwide problem, as illustrated in the data from the National Survey on Drug Use and Health. 25 years of evidence show that Pcapp can improve the health and stability of at-risk mothers and their children. Washington State Pcapp provides a model for other states to help affected mothers build healthy families. And I think also the methods that are used by Washington State Pcapp can be used in other contexts to help mothers with substance use disorders achieve and maintain recovery. If you're interested in more information, you can see our website at www.pcappwa.org. You're also welcome to contact me directly. My email address is sastoner@uw.edu. And in case some of you out there, know somebody who would benefit from being referred to Washington State Pcapp, information about referral can be found at bit.ly/refer to Pcapp, and capitalization actually matters. So I just want to end with a final quote by a Pcapp client to just kind of sum it all up. I think this really nicely captures the impact of Pcapp. Pcapp was there to encourage me in making all the right choices for my son, setting goals I knew I could achieve, and helping me succeed. Without their support, I wouldn't be where I am today. I have my own apartment, a car, a job, my son, a relationship with my daughter. I have 4 years off meth, 2 years off alcohol, 2 years off weed. Trust me, my key Pcapp worker showed me tough love. Thanks for encouraging me, helping me through. Thank you, Pcapp, for giving me hope. So here are the references. And again, please look for our surveys in your inbox. We do really appreciate your feedback. Every survey we receive helps us improve and continue offering our programs, and I will give an extra emphasis on that as the NWATTC Data Operations Specialist. The link is bit.ly SUD_February 24. And again, punctuation matters. The survey only takes 1 minute to complete, so please do that. And thank you very much. So we have some time for questions.
Yeah, so Susan, I went ahead and kind of compiled some of them. So I'll just go ahead and ask those in the order that they were received.
Okay.
How has the pandemic affected women and children you serve? And what changes have you made to adjust the program? And then a second part to that is, how have you handled home visits?
That's a really great question. The pandemic has been a real challenge for the sites, and it hasn't always affected the state uniformly. Different counties have entered and left and re-entered different phases of lockdown. And so the sites have actually had to be really adaptive and to sort of find the way that works best for them. Obviously, going into homes and providing transportation has largely not been possible just because it's not safe to do so. But we've been really sort of creative in finding ways like doing drop-offs at people's homes of like diapers or things like that, sort of talking from a distance, meeting outside, meeting, via, text messaging or FaceTime, staying in contact that way. So sites have really had to be creative about that. There was also some discussion about, whether we would have to participate in contact tracing. And so we really wanted to try to avoid that happening. And to my knowledge, that hasn't been an issue. That's really a great question.
Great, thank you. How can this program be brought to other states that don't have an existing Pcapp program?
That's a great question. As you might imagine, starting Pcapp program takes a lot of preparation work. We actually have a section on our website that speaks to starting a site. But if you're going to bring Pcapp to another state, depends on like is it just going to be one site, or is it going to be like a network of sites like we have here in Washington? If it's a network of sites, you really need buy-in from the state and hopefully support from the state to help get that off the ground. You also really need to sort of do a needs assessment and kind of a landscape survey of what the available resources are in the particular community. Are there places to refer clients to for mental health services, for substance use treatment, for educational opportunities, all of those things that really provide, really support long-lasting recovery. If you have that, and you're interested in exploring starting a site or a network of sites, definitely encourage you to reach out to me We will often provide consultation and training to sites outside of the state of Washington who are looking to implement Pcapp. And one thing that I've tried to focus on since I've become the Pcapp director is really thinking about scalability, because we are increasingly getting asked for consultation to expand Pcapp, which we love because we really believe very strongly in Pcapp. But of course our first priority is Washington State Pcapp. So trying to put in place different ways to sort of help implementation in other states and even in other countries.
Great. I don't know if we could go back to that slide, but I got a couple of questions about which states have the existing Pcapp programs, and I think you already touched on that. But maybe if there's
let me see, it's before the outcomes. It's in the history of Pcapp slide, I believe. No, before that. No. There we go. So yes, Pcapp has been replicated or adapted in some way in Minnesota, North Carolina, Alaska, Texas, Nevada, Louisiana, Pennsylvania, Michigan, California. And there are a number of sites in Canada and one in Western Australia. When we've talked to people in a couple other states who are looking at implementing a Pcapp program.
Great, thank you for going back to that slide. What other program options similar to Pcapp are available to mothers under the age of 18?
That's a great question. And I'm actually not aware of other programs that specifically target mothers under 18. Historically, Pcapp in Washington hasn't enrolled mothers under 18 because it was originally connected to a research study. And in the context of a research study, if you enroll research subjects under the age of 18, you need to get parental assent, and then that just gets kind of messy. And so we just left it at 18. But I think that's something to kind of consider if, like, say, there were mothers under the age of 18 who were emancipated or didn't have the sort of family dynamic of parents who perhaps don't are interfering with their participation in the program. Might be this something like Pcapp would potentially work for them. But yeah, I'm not aware, currently I am not aware of any resources to mothers under the age of 18. It really wasn't designed, Pcapp really wasn't designed to be a teen or adolescent focused intervention, and there are important developmental differences between teens and adolescents and adults. So, we'd have to really think about, how a program like this would work for and be developmentally appropriate for someone under the age of 18. I don't think it's necessarily out of the question, but I think it takes some careful consideration.
Great, thank you for covering that question. I'm going to try to summarize this one. You mentioned that people in the program must not be connected to services, and to what extent does that go to? For instance, if a patient is using Suboxone prescribed by her physician and struggling with relapse from time to time, what about if they're using state-assisted housing? Do those affect that?
Oh, that's okay. Yeah, no, didn't mean to imply that they can't be connected to any services. I mean, certainly, if individuals are already connected to some services like substance use disorder treatment, medications for opioid use disorder, something like that, that's great. They just can't have all of their needs being met, right? Or else how can we what the question becomes, what do we have to offer them? If they're already connected to everything that we could get them connected to. So there just needs to be some demonstrated need there in terms of, they could benefit from getting additional services that they are not getting. So it's not an absolute kind of thing.
How do you engage other family members in these services, like the father or grandmother, grandparents, etc.?
That's a good question. Thinking back to our model of case management, the client is really at the center of the model. So the client, would kind of be the gatekeeper to other, other important relationships in the client's life. So in terms of working with, like say the father of baby or other family members, we can certainly do that, have some interaction and provide some support to other family members with the participation and support of the client. But we have to keep in mind who the client is. I will say there's been a lot of interest in finding ways to offer more services to fathers. And we don't have any formal way of doing that now. Like we don't, for example, have like dedicated case managers for fathers. But that's something that I think is certainly worth thinking about, and it's an important population to serve. And certainly fathers could use support as well. And whether that is, fathers of children who are already connected to Pcapp, or whether they're single dads. I think it's a population that I think could benefit from support. We just would have to figure out a way to do that, and maybe perhaps come up with a pilot program if we can, devise some, like find a good site to do that with, for example.
Great, thank you. Can you review the referral process to Pcapp again, kind of summarize that?
Yeah, so pretty much anyone can make a referral to Pcapp. Individuals can self-refer, or service providers can make a referral. We have information on our website under Contact Us, how to make a referral, and I created a bit.ly friendly link there. But basically, if you're in Washington State, you would want to look for the county that you're in and ensure that there is a Pcapp site that covers that county. And then, we provide contact information for all of the clinical supervisors at those sites, and they'll take the information. Pcapp doesn't make cold calls, so we want to reach out to people with their permission. Yeah, we want to definitely determine that the individual met criteria, and then the clinical supervisors would take it from there.
Great. I think we have time for maybe one more question, then I'll do some closing remarks here. I know you answered this in the chat box, but I just thought it was a pretty good question that maybe the rest of the audience would like to know about. Are homeless women able to participate in Pcapp?
And that's an emphatic yes. And that's, I say, we emphasize home visits whenever possible, but that's not meant to mean that we exclude women without, or clients without homes. I mean, if the client's home is their car or, a tent, case managers have been known to go there. I think, really the emphasis is to meet the client where they are. And so we definitely, and certainly homeless women or homeless clients are presumably not well connected to services, and that is a population where we could potentially really help. So absolutely, we welcome homeless clients.
This one might be a short one or a quick answer. What does the availability look like at Pcapp, and what's the waiting list?
That's a great question, and I can't really answer it in a single answer. I mean, I think it really depends on the site, and maybe some of the Pcapp case clinical supervisors who are on could quickly say in the chat box if they have a waiting list. I think for the most part, there aren't really many waiting lists. But, you know, again, that, like I said, that varies from site to site. Okay, one of the clinical supervisors says Pcapp sites can make room for emergent needs, but we do maintain wait lists, which are short in time.
Great.
So that sounds like a kind of a good statewide answer.
Thank you for answering that. I'll go ahead and do a couple of closing things. So just to let everyone know, there will be a recording and these slides available on the Northwest ATTC website, and that should be available later this afternoon. Please make sure you fill out our evaluation survey that Susan mentioned. The link is in the chat box, but it's also listed on the PowerPoint slides for today. And then be sure to join us for our next webinar on March 31st. It's titled Daily Cannabis Use During Pregnancy and Postpartum, Patient, Provider, and Bud Tender Perspectives. And that's presented by Dr. Celestina Barbosa-Leiker. And I just want to thank you, Susan, for your time today. It was a wonderful presentation. And Meg for doing all of the tech in the background, and our participants for taking the time to join us today.
I just want to say, you know, I've seen some questions in the chat box that I haven't been able to get to. And I just want to say you're more than welcome to email me directly at sastoner@uw.edu if you have any questions that you'd like me to address. And thank you all for joining us today. I'm really pleased to have the opportunity to speak to you.
All right. Thank you, everyone.